This is the fourth video in this series on hemostasis, and today I'll be discussing tests of hemostasis. The learning objectives are first, to list the conventional tests of hemostasis and to describe how they are performed. These will include the platelet count, PT, and PTT. Next, to list the common etiologies of abnormal results of these tests. Then to describe how to approach an abnormality of PT or the PTT. And last, to interpret typical coagulation profiles. This video will start to introduce a few medications and common disorders of hemostasis, such as von Willebrand disease, hemophilia, and the antiphospholipid antibody syndrome. However, I won't be talking about these conditions in any depth here. Rather, they'll each be discussed in future videos in the series. Let me start by discussing the indications for hemostasis tests. To identify which patients presenting with acute bleeding have a correctable bleeding tendency, for example von Willebrand disease, hemophilia, and disseminated intravascular coagulation, just to name a couple. To identify which patients presenting with acute clots have a correctable clotting tendency, such as antiphospholipid antibody syndrome. To monitor response to anticoagulant medications, such as warfarin and heparin. To aid prognostication for patients with liver failure, for example, the PT test is used to predict mortality both in alcoholic hepatitis as part of a calculation called the discriminant function, and in cirrhosis as part of the MELD score. To screen for disseminated intravascular coagulation, commonly known as DIC, in patients with severe sepsis. And last, to screen for occult bleeding disorders prior to surgery or other invasive procedures. This last indication is controversial, and I'll talk more about it at the end of the video. I think about hemostasis tests in two categories. First are the common tests. These are the ones that I see ordered all the time in the hospital. They include the platelet count, PT and INR, the APTT, which is more commonly referred to as just PTT, fibrinogen, and D-dimer. Then there are the uncommon tests, which are ordered only in very specific situations. The only uncommon test I'll discuss more in this video is the mixing study, which is important in evaluating an increased PT and particularly PTT. However, there is also the Prothrombin Time, which is a measure of the function of the common pathway. Although textbooks generally make a point of discussing this test, in over 10 years of internal medicine, I've never seen it ordered once or recommended by a hematologist in real life, and therefore won't be talking about it. Next is the activated whole blood clotting time, tests of anti-10A activity, and the Etiologies clotting times. These are all used exclusively to measure anticoagulation effect from specific medications and will be discussed in the anticoagulation video. Then there are various tests of antiphospholipid antibodies, qualitative platelet function, and heparin-induced thrombocytopenia. These three will be covered in future videos as well, at the same time as the relevant conditions are discussed. Not listed here is an archaic test called bleeding time, in which a standardized nick is made in a patient's skin, and the time it takes for it to stop bleeding is measured. Although mention of it still creeps into some review books, the test suffers from poor reproducibility and is essentially no longer performed. The first test to discuss in depth is the platelet count, which is both the most basic and also the most common of all hemostasis tests. Platelet counts are tested on machines called autoanalyzers as part of the complete blood count, which is a broader panel of hematology tests that also includes hemoglobin concentration and white blood cell count. The test must be performed on blood collected in an anticoagulated specimen vial, which is usually purple-topped, indicating that it contains EDTA. There are many etiologies of quantitative platelet abnormalities. A platelet count that is too low, a derangement known as thrombocytopenia, can be due to either decreased production of platelets, increased destruction, or hypersplenism, also known as sequestration. Decreased production is most commonly due to bone marrow disease, such as infiltration by cancer or systemic infection, or due to nutritional deficiencies such as B12 and folate deficiency. Decreased production is typically accompanied by decreases in the other cell lines of red and white blood cells as well. Now, increased destruction can be due to any of a very long list of medications along with alcohol. Also, autoimmune disease such as idiopathic thrombocytopenic purpura and DIC. A platelet count that is too high, usually called thrombocytosis, can be reactive in response to infection, surgery, particularly splenectomy, malignancy, or acute blood loss. Much less commonly, thrombocytosis is a consequence of a myeloproliferative disorder. Both thrombocytopenia and thrombocytosis will be the subjects of their own videos later in the series. One additional quantitative platelet disorder that should be discussed is pseudothrombocytopenia. This refers to a falsely low platelet count as a result of lab artifact. It's relatively common. There are two main etiologies. The more common of the two is incomplete mixing of blood collection tubes, which causes small clots to form, which then traps platelets and confuses the autoanalyzer. A less common etiology is EDTA-dependent agglutins. In this case, in order to get an accurate platelet count, a different anticoagulant must be used. Pseudothrombocytopenia can almost always be identified from a review of the peripheral blood smear, as in this case when we can see the extreme platelet clumping. The next test to discuss is called the Prothrombin Time, or more commonly just the PT. To measure the PT, whole blood is collected into a sealed, evacuated tube, which by convention is blue-topped, signifying that it contains citrate. The citrate binds calcium in the blood, which prevents the blood from coagulating. To maintain accuracy, a standard amount of blood must be collected into the tube such that the ratio of blood to citrated solution is also standardized. The whole blood is then centrifuged to separate the blood cells from everything else. The blood cells are then discarded, leaving a translucent yellowish fluid called plasma. Plasma is essentially the liquid portion of blood and predominantly contains electrolytes, albumin, immunoglobulins, glucose, and of course, clotting factors. To the plasma is added calcium and a substance called thromboplastin, which is a mixture of tissue factor and phospholipids. If we look back at the coagulation cascade from the video on normal hemostasis, we will be reminded that tissue factor is present here as the primary trigger for the tissue factor pathway, also known as the extrinsic pathway. Therefore, when added to plasma along with calcium, a fibrin clot will form. Macroscopically, this changes the translucency and color of the plasma and will transform the free-flowing liquid into a solidified gel-like substance. Any of those changes can be used by either a machine or a human being to determine when the clot has formed. The PT is defined as the time in seconds for this to happen. From the coagulation cascade diagram, you can see that this is a measure of the function of the tissue factor pathway. However, it is also a measure of the function of the common pathway, since deficiencies or abnormalities of thrombin, fibrinogen, factor V, or factor 13 will also lead to delayed clot formation. The normal range for the PT is about 11 to 14 seconds, but this has high variation due primarily to differences in the manufacturer's thromboplastin, but also due to differences in incubation time, differences in the storage conditions of the samples, and differences in the method of endpoint detection. This is actually a big problem, particularly for patients on anticoagulant medications affecting the tissue factor pathway, such as a medication called warfarin. For example, the degree of anticoagulation a patient on warfarin might be experiencing could be labeled appropriate by one lab, too much by another, and too little by a third. This inconsistency made it very difficult to publish standardized guidelines about how these drugs should be used and monitored, and it made it impossible for a patient on warfarin to have their coagulation profile monitored by more than one lab. However, in the early 1980s, to account for this variation, a derived value called the International Normalized Ratio, or INR, was developed. The INR is calculated as the patient's PT divided by a controlled PT raised to the power of something called the ISI, which stands for the International Sensitivity Index. The ISI is specific for each lot of thromboplastin reagent. The ISI of each lot is provided by the commercial vendors of thromboplastin, but should be independently confirmed by the clinical laboratory. This didn't completely eliminate the problem of standardization, but it greatly reduced it. A normal INR for someone not on anticoagulation is 0.8 to 1.2. So what are the etiologies of an abnormal INR? Well, first, is there such a thing as an INR that is below normal? There is, but an INR significantly below normal is very uncommon, has been poorly characterized, and is of unclear clinical significance. In other words, unless you're a hematologist, you'll probably never need to worry about it. However, there are many causes of an elevated INR. They can be subdivided into some anticoagulants, those associated with a decreased synthesis of clotting factors, which can be from chronic liver disease or vitamin K deficiency, and those associated with an increased consumption of clotting factors such as sepsis and DIC. The next test to discuss is the activated partial thromboplastin time, frequently called the PTT. I don't actually know why everyone always drops the A when saying it aloud, but they do. This test is nearly identical to the PT, with one important difference. Once the plasma has been separated from the cells, instead of calcium and thromboplastin, calcium and something called partial thromboplastin is added. This partial thromboplastin consists of phospholipids without tissue factor. And without tissue factor present, an activating agent must be added in its place, which is often silica or diatomaceous earth. As with the PTT is the time in seconds it takes for the fibrin clot to form. The PTT measures the function of the contact activation and common pathways. The normal range for the PTT is about 25 to 40 seconds, but it has substantial variation across different reagents and testing systems. Unlike PT and the INR, there is no equivalent standardization of the PTT, and therefore each lab and hospital should establish their own normal range and adjust anticoagulation protocols accordingly. Having been the one responsible for coordinating such an adjustment once at a hospital, I can attest to the fact that the process is haphazard and inexact, which is why I personally have very limited confidence in the safety of infusions of unfractionated heparin, which rely on the PTT test for titration. This will be discussed more in the video on anticoagulant medications. There are a fair number of causes of an elevated PTT. They include anticoagulants again, a genetic defect in von Willebrand factor, predictably called von Willebrand disease, hemophilia, antiphospholipid antibodies, sepsis, and DIC. The next test, fibrinogen, is not ordered nearly as frequently as the PT and PTT, but it's still not rare. To remind you, fibrinogen is a glycoprotein critical for both the formation of the platelet plug, as well as serving as a precursor for fibrin, which is the penultimate step of the whole coagulation cascade. Fibrinogen is synthesized in the liver, and its normal range is around 200 to 400 milligrams per deciliter. Most abnormalities of fibrinogen are quantitative. However, both thrombophilic and hemorrhagic versions of congenital dysfibrinogenemia also exist, in which measured levels of fibrinogen are normal, but these are very rare. Quantitative abnormalities of fibrinogen can either be high or low. High fibrinogen can be seen as part of a general increase in so-called acute phase reactants, which are a collection of compounds in the blood whose levels increase in response to nonspecific tissue injury, inflammation, or infection. Other acute phase reactants include ferritin, C-reactive protein, C3, and C4. High fibrinogen is also frequently observed in normal pregnancy. Low fibrinogen is predominantly seen in two conditions, liver failure and DIC. The last of the common hemostasis tests is the D-dimer. As mentioned in the last hemostasis video, the D-dimer is the most clinically relevant of the numerous types of fibrin degradation products. It consists of two D domains from adjacent fibrin monomers. Thus, the presence of D-dimer requires recent intravascular coagulation. The normal range is less than 0.5 milligrams per deciliter, which is sometimes expressed as less than 500 micrograms per deciliter. There are many causes of an elevated D-dimer. The most clinically relevant include venous thromboembolism, such as a PE, arterial clot anywhere, DIC, severe sepsis, malignancy, recent surgery or trauma, liver disease, and once again, normal pregnancy. So those are the 5 main coagulation tests: platelets, PT or INR, PTT, fibrinogen, and D-dimer. When one considers all 5 together, the group is considered a coagulation profile and often can be collectively ordered as something called the DIC panel. Let's review what typical coagulation profiles look like for some common diseases. In advanced liver disease, platelets will be low due to hypersplenism and splenic sequestration. The INR will be high due to impaired production of clotting factors, and the PTT can also be high or is occasionally normal. Fibrinogen will be low, and D-dimer will either be normal or elevated. In DIC, platelets are low. The INR and PTT are either normal or elevated. Fibrinogen is normal or low, and D-dimer is usually elevated. Although not included in this panel, the other key finding in DIC is a so-called microangiopathic hemolytic anemia, identifiable by encountering red blood cell fragments called schistocytes on a routine blood smear. In von Willebrand disease, platelets are usually normal but occasionally mildly decreased. INR is normal, PTT is normal or elevated, and both fibrinogen and D-dimer are normal. In both hemophilia and antiphospholipid antibody syndrome, often the only abnormality is an elevated PTT. And in pregnancy, platelets can be either normal or low. The INR and PTT are normal, and fibrinogen and D-dimer are elevated. The condition in which an otherwise normal pregnancy is accompanied by mild thrombocytopenia is called gestational thrombocytopenia, which is important to distinguish from a serious complication of pregnancy called HELP syndrome. The HELP is not like the word help, as I can get some help, but rather an acronym standing for hemolysis, elevated liver enzymes, and low platelets, which are the 3 main features of the disorder. All of the diseases in this chart are going to be discussed in more detail later in the series. Now, among the tests that I designated at the beginning of the video as uncommon, there is one which merits discussion here. That is the mixing study. Clotting tests can be abnormal due to either a clotting factor deficiency or due to the presence of an inhibitor of normal factor activity, usually an antibody. A mixing study differentiates between these 2 possibilities, and it relies on the observation that clotting tests generally only require factors to have 50% or sometimes even less of their normal activity in order for the test to be normal. So here's how a mixing study works. Some volume of the patient's plasma is literally mixed together in a 1-to-1 ratio of pooled plasma from normal individuals. Then the initially abnormal clotting tests are rechecked. If the abnormal clotting test normalizes, the patient must have a factor deficiency because whichever factor was deficient in the patient's plasma has been supplemented by the normal level of that factor in the normal plasma. But if the clotting test does not normalize, the patient must have a factor inhibitor because when factor inhibitors are present, their concentration is usually high enough to inhibit the additional factors added to the mix from the normal plasma. The one caveat to this relatively simple test is that some inhibitors require time to inhibit the clotting factors that have been added from the normal plasma. Therefore, if the clotting times in the mixture are normalized when checked initially, the test should be repeated and the mixed plasma allowed to incubate at 37 degrees for several hours before checking once more. The lab should then report both the results of the mixing study when performed immediately and when performed after incubation. So now let's put all this information together into a helpful, practical algorithm for investigating abnormal coagulation tests, that is, focusing just on the PT and PTT. There are many algorithms out there on the internet, and they actually vary quite a bit. but this is the one that makes the most sense to me and most conforms to my own clinical experience. Importantly, this algorithm assumes the patient is on no anticoagulant medications and is not critically ill. If either the PT alone or both the PT and PTT are prolonged, then give the patient vitamin K. If the test or tests correct, you have your diagnosis, vitamin K deficiency. If there is not correction, next consider whether the patient has severe liver disease. If they do, the prolonged clotting times are almost certainly due to that liver disease. This isn't necessarily true 100% of the time, but if a patient has both severe liver disease and another completely independent clotting disorder, it will be very challenging to diagnose the latter, and if that's a consideration, you should consult a hematologist. If the patient either has no liver disease, or if the liver disease is mild enough that a secondary clotting disorder seems unlikely, then perform a mixing study. And if between the PT and PTT only the PTT is prolonged, then go right to the mixing study. From the mixing study, if the prolonged clotting corrects, next check the patient for von Willebrand disease and measure specific factor activity levels. On the other hand, if there is no correction, next check for antiphospholipid antibodies and specific factor inhibitors. So I'm almost at the end, but there are just two very quick practical topics that also need to be mentioned. First is the interpretation of coagulation tests in patients with liver disease. It's commonly believed that liver patients with abnormal coagulation panels have an increased risk of bleeding. On the wards, I often hear the term auto-anticoagulated, particularly in the context of the decision to not place a patient with cirrhosis on DVT prophylaxis. However, the reality is much more complicated. There are reduced levels of most procoagulant factors, that's true, but also most anticoagulant factors as well. There are actually increased levels of factor VIII, and while there are frequently reduced platelet counts, which predispose to bleeding, there are also increased levels of von Willebrand factor and decreased levels of ADAMTS13, which may predispose to clotting. Therefore, liver patients with markedly abnormal coagulation tests may actually still be in hemostatic balance, but it's a much more precipitous balance. In addition to decisions about DVT prophylaxis, the other scenario in which this comes up is when a surgeon or other proceduralist requires a liver patient to receive transfusions of FFP in order to drive the INR down below some arbitrary value prior to performing a procedure. In the absence of other evidence that the patient is at high risk of bleeding, this is probably not justified, particularly if such a transfusion will either risk volume overload or will delay a critical, time-sensitive intervention. Finally, I will end with a few words about the use of coagulation panels to screen for bleeding disorders in asymptomatic patients, particularly those with no family history. I started off this video with a list of common indications for coagulation tests, and this is one of them, but it probably should not be. So first, it's very common for the INR and PTT to be checked before routine surgeries and other procedures. However, the INR and PTT have low sensitivity and specificity for bleeding disorders. The rate of clinically significant but occult bleeding disorders in otherwise healthy people is quite low. And personal or family history of excessive bleeding is much more predictive of perioperative bleeding than coagulation tests. Therefore, many experts recommend an emphasis on personal and family bleeding history when predicting operative bleeding risk, and explicitly recommend against the use of coagulation tests for this purpose. In my own practice, I will still frequently order preoperative INRs and PTTs in otherwise healthy people, but that's only because those performing the procedures usually insist on it. This is not necessarily a battle worth fighting with your hospital colleagues. So that concludes this video on the tests of hemostasis. The next 3 videos will discuss medications which alter hemostatic balance, specifically antiplatelet drugs, anticoagulants and fibrinolytic meds, and the less commonly used pro-clotting meds.